Hi, everybody. Good evening, good afternoon, good morning, wherever you are in the world. I am about to do a live with Dr. Smikle, who is the medical director of Laurel Fertility Care, who are a fantastic boutique clinic based in San Francisco. And today's topic is all around cancer and fertility, options, treatment plans, effects, everything that you want to ask and know. It's Breast Cancer Awareness Month this month, so it's very fitting that we cover this and have all of these brilliant questions answered by Dr. Smikle, who is a world-renowned fertility expert. So I'm going to see whether he's here now. Please have any questions ready. It's an interesting conversation, so we look forward to welcoming you today. Hi to those who are joining. Nice to see you today. Hi, Dr. Smikle.
Hi, how are you doing?
Very well, thank you. How are you?
I'm doing okay. I can't complain too much. Sorry, I'm adjusting
Good.
everything.
Good. Well, thank you so much for joining us today. It's always such a pleasure. I just gave you a brief introduction as a world-renowned fertility specialist, the medical director of Laurel Fertility Care, boutique clinic based in San Francisco. We do our regular monthly Instagram lives, which are fantastic, very, very educational and inspiring. So thank you for your time today. And we are going to be discussing cancer and treatment options, plans, amazing questions that people have sent in and that we've got to ask you today. It's October, Breast Cancer Awareness Month, but we're going to be touching on different types of cancer and treatment options. So please do introduce yourself, and then I have questions to ask you if you're ready.
Okay, perfect. My name is Colin Smikle. As she said, I'm the medical director at Laurel Fertility Care. We have offices here in San Francisco with satellite offices in Modesto and Oakland. And we've been serving patients for more than 15 years now and serve quite a few patients with fertility challenges related to cancer treatment. So thank you for inviting me to kind of participate.
Absolutely, absolutely. So Laurel Fertility Care, you've just mentioned that you've seen many patients who have been affected by cancer and fertility. What's your approach when people come to you, perhaps following a cancer diagnosis or following treatment, cancer treatment?
Well, there are two groups of patients, if you will. There are patients who are um, recently diagnosed with one or a different type of cancer and are really looking at their options in terms of how to preserve their fertility. And many times it will come up in terms of they were told by their oncologist that they should actually consider fertility treatment or at least preservation treatment because some of the treatments that they're going to undergo may affect their ability long term. It does depend on the type of cancer, so therefore, different cancers are going to be looked at very differently. Some will actually not really affect fertility as such, so therefore it's not as great a concern. But there are others that will definitely impact fertility, and therefore they're going to actually have to consider that. This is Breast Cancer Awareness Week, so therefore it's easy to understand and hear that that's one type of cancer that because breast cancer may be hormonally related, that going through fertility treatment is going to be really important because going through and preserving embryos now may affect their long-term issues in the near term. But more importantly, the treatments that are going to be considered for managing some specific types of breast cancer may involve removing any possibility of fertility in the future, meaning that removing ovaries. Mm-hmm. And so therefore it's very important to make sure that those individuals are counseled and are basically evaluated so they can actually preserve that opportunity, if not for themselves, using a gestational carrier later on. So therefore that's going to be a really important factor to kind of consider.
I also presume that there is normally urgency behind it if someone has had a diagnosis. So what would be the next steps? And I presume also thinking about people who are looking at fertility options before or after treatment, cancer treatment. Um, am I right in thinking chemotherapy is detrimental to fertility as well?
Well, many types of chemotherapy agents may be detrimental to fertility treatment. If you look at chemotherapy in different measures, if you will, ones that are what we call alkalinizing agents, they're actually going to bind with DNA and therefore affect egg development, and therefore affect things long term. That'll actually then diminish the number of eggs that are going to be available later on. So therefore, those are the type of treatments that are going to be really critical in terms of making sure you're going to preserve their opportunities now. Oftentimes, those patients are not being told, are seen by us initially, they're seen by their oncologist, and their oncologist may either refer them directly or say, look, you need to start exploring these options now. And so those patients are going to be called in frantically, and those are the patients who are going to jump the line, so to speak,
Mm-hmm.
because they may not have time to wait. And so we're going to see those patients somewhat urgently, and we may begin treatment, at different phases in terms of their menstrual cycle. And what I mean by that is just that typically when we're going through and we're evaluating patients, we go through this long approach, if you will, to kind of give the person the best options in terms of preserving for the future. Whereas with cancer treatment, you have to basically do a lot with a very short time frame, because some individuals will end up having a time frame in terms of when chemotherapy will start. And so therefore we're trying to fit that entire cycle into that time frame that they have. And some patients are going to go through rounds of chemotherapy. And so we're fitting in their embryo cryopreservation options in between those rounds, realizing that we need to make sure there's sufficient rounds afterwards that's going to prevent them from having recurrence.
And this is men and women, isn't it?
That is true. Men, it's a little bit different in terms of, men will actually have a much better option in terms of recreating sperm afterwards, because men make sperm every day. It may take a longer period of time, but at that point, and at least, if they produce sperm now, they can freeze it for the future, and it's not going to be a burden. Women, if they're losing eggs, or especially if it involves surgery where they're going to remove parts of the ovaries, those are women who they're not going to end up having that potential return. So therefore, theirs is going to be a much more direct and much more, challenging, endeavor to make sure we preserve enough of an opportunity to basically, have them, be successful in the future.
Mm-hmm. And what about cancers such as cervical cancer?
Cervical cancer and those type of cancers, thankfully, are not as frequent as we saw in before. The incidence has gone down considerably. A lot of it has to do with that they're a much more they were much earlier in terms of investigating and diagnosing them before they would turn into a true cancer that's going to end up requiring removal of all the structures. Those individuals are a little bit different in terms of, when you're talking about treatment for cervical cancer, it may involve removing the uterus, not as much using removing the ovaries. So therefore, those individuals are going to then be counseled regarding their need to use gestational surrogates in the future. So for that, for those individuals, it adds a little bit different challenge, if you will, because we need to not only preserve that opportunity, but do it in a way that then is going to then comply with a lot of the FDA guidelines for management in terms of using a gestational carrier. The burden is not that challenging from the standpoint of making sure that the timeline lines up, if you will.
Mm-hmm.
It just needs to going through that extra hurdle in terms of making sure we're compliant and getting all the labs and everything else for them to kind of consider.
Would you tell you mentioned that you do a lot of fertility care. You do see patients who are looking at fertility options pre-cancer treatment and post-cancer treatment. Which is more common, pre-cancer treatment or post? Would you say?
Pre-cancer treatment requires more urgency, so therefore, from those individuals, we don't have much time, and there's a lot of counseling. And fortunately, we've been successful in terms of basically helping those individuals through the process. A lot more comes into post-treatment individuals where they're coming in and they've been given the go-ahead by their cancer oncologist, and they're saying that now they're ready to basically begin that process. Those who are fortunate to have eggs or embryos or sperm frozen before that diagnosis are in a better position because you're not really having to go through and recreate steps, if you will. But still, we have some individuals who either were not in an environment where they had the opportunity to, or weren't fortunate enough to freeze embryos before, or freeze gametes before, so we're having to meet them then. I'll start with men to say that, from the standpoint, the easiest thing to do is to basically do a sperm assessment to see if there's any sperm that's there. Depending on the type of diagnosis that was before, you can expect that, you may be able to start stimulating and then hopefully have recovery of sperm development. Whereas in women, it's going to be ones where you may end up having, a significant challenge in that the eggs that develop afterwards, they've been affected now with chemotherapy agents, so therefore they may not have as many, and it may take them a lot more effort to kind of go through and create new ones. The balance with that, though, is in those individuals, you're also dealing with the burden of if those cancers are going to be sensitive to hormones such as estrogen or progesterone, the stimulation approach itself may stimulate that cancer to recur. So you have to be really judicious and work with their oncologist to make sure you're not going to basically push them further into a situation where, yes, they're trying to build their families, but you're leaving them with a detriment that can actually, be impactful. So it's always walking that line, if you will, in terms of what's going to be the best approach.
Mm-hmm. And I presume for people who may not have had the chance or opportunity to freeze sperm or eggs, what are the options there? Donor eggs and sperm?
In women, even if they do have the capability of basically, providing eggs, if their cancer is going to be one that is truly going to be sensitive to hormonal stimulation, then we have to counsel them just as the oncologist would, that basically getting pregnant may not be the right option. Or getting, try to get that is not going to be the right opportunity. Because, that's going to then, create a situation where, yes, they can get pregnant, but then they're going to be impacted by having a shorter lifespan. And, fortunately, we don't have as many of those patients that we have to manage, simply because we're going to counsel them out of basically making those decisions.
Yeah.
And then they can consider using a donor, egg donor, or even a gestational carrier as a measure for going through. Mm-hmm. Sperm donor is an approach if, men having no sperm. So there are definitely ways in terms of having conversations around those choices based on what their circumstances are.
Mm-hmm. And in terms of difficult conversations and choices that people might make and being given the information to make those decisions with, do you have counsellors that you work with who specialise in this area? And also, are some of these illnesses things that are hereditary, where it might mean that the risk of a child having something is higher?
Great question. I think, the key thing is that we do work with a wonderful group of counselors who basically can help them navigate this. None of them are actually employed directly by Laurel Fertility, but we do partner with groups who basically can provide that information. So that's been really helpful. But more directly, if individuals are going to be impacted such where their cancers are going to be ones where we have to then, be concerned or worried about, then we're going to end up having to, talk to them more directly about approaches about what to do. So yes, we actually have the ability to do both, and I think that's going to be important.
So, for example, with it being Breast Cancer Awareness Month, for women who know that it runs in the family, would you suggest that as well as having checkups, they look into their fertility options at an earlier age, just to ensure that they have all the options to hand if there is an increased risk of potentially developing it?
Well, BRCA 1 and 2, and there are now other breast cancer profiles that we know are hereditary. So therefore, there are individuals who basically, either their mother or another relative has been known to have breast cancer, and therefore they're finding out that they're going through the process testing themselves.
Mm-hmm.
And in those individuals, we've gone through the process where, especially if we have the time and it's not as urgent because they themselves don't have a diagnosis of cancer, we can go through and then, go through treatment a lot more directly to maximize their opportunity. There are also individuals who are really considering the fact that they also don't want to then transfer this gene onto their children. And so what you can do is you can create the probes to remove this gene profile from the embryos that you're actually considering for transfer. So we have the opportunity for both. We don't have it as much in terms of patients who are actually going through active treatment, only because typically we're not getting as many embryos in terms of testing, and we don't have the time to create the specific probe. And you can't go back and create the probe once the embryos are frozen. So therefore you're left with basically just some start decisions. Those individuals where we do have that opportunity to be more directed, yes, we do have the ability to basically create those probes, assess the embryos, and not passing it on to their offspring.
Mm-hmm. If anyone has any questions around this topic for Dr. Smikle, please do DM us. If you don't want to put them in the comments, he's always happy to answer them and give you a consultation and speak with the rest of the team. If someone has had, I know we've talked a lot about preserving fertility. If someone has had cancer treatment and they want to start their family and look into their options, is there a set amount of time that you'd have them wait before they can start treatment with you?
Well, fortunately, many of those individuals are coming back to us after they've consulted their oncologist, and their oncologist is the one who gives them the go-ahead to say, look, you've been cancer-free for this period of time. The risk of recurrence is going to be low, so therefore now you can start that process to consider. Because going through and considering breast cancer as an example, breast cancer, typically there's a 1, 3, and a 5-year survival that you have to consider. Most oncologists would probably say the earliest time you'd end up considering any treatment would be at 3 years, and even then, many would actually recommend waiting until 5 years because then you have a much lower chance in terms of recurrence and a much more likelihood that you're going to end up having longevity, even if there were a recurrence. So, the key thing is basically timing things based on, when, the expected recurrence. Mm-hmm. No one's going to say, basically at the 1-year mark that, it's okay to kind of do things now, only because essentially we know that, recurrences occur, usually, after that 1-year mark. So therefore, typically you're talking about the 3 to 5 year time frame when you're going to start to consider.
Okay. Thank you so much for your expertise on this. And if someone conceives following cancer, is that classified as a high-risk pregnancy?
Many times, no. Many times the process itself is actually, the pregnancy is actually not considered a high-risk pregnancy. That person will be monitored differently. So therefore, I'm not saying that person is then going to be considered totally normal. But that person may be basically being followed by a team, including an oncologist, only because they're going to be, monitored to make sure that there's not a recurrence. But the individual can actually deliver naturally if that's going to be their choice. The hard part comes in is just that sometimes, we go through all these expectations and then we find out that a recurrence does occur during the pregnancy. That converts it to a high-risk pregnancy, because at that point in time, you're going to have to make some restart decisions. Right. Most times what you'll actually do is to basically, if you have the opportunity to get through a point of viability, but viability is not necessarily full term. So therefore, those individuals, let's say a person with breast cancer, what you may be doing is considering, delivering at 35, 36, 37 weeks, when there's a greater chance that basically you'll end up having fetal survival with very little long-term effects. And so those patients may end up having an induction or a scheduled C-section so you can start treatment right away. Many of those individuals may end up going through where they're going to end up having the delivery and then not breastfeeding because you're going to end up directly going at chemotherapy afterwards. and then basically trying to manage the recurrence of the cancer at that point in time. So that's a lot different.
Gosh, lots to think about.
It's pretty hard conversations to have, yes.
Absolutely, absolutely. And some of the more common cancers, I guess, that we've heard about in the community around fertility, and we've had some wonderful people in our community who have written about their stories of cancer and how it's affected fertility in their journeys, which you can find on our website. I think breast cancer, cervical, colon, testicular, thyroid, leukemia. Is there you sort of touched on it, but is there a more specific approach and plan dependent on the type of cancer that you've got or had?
The main reason why basically lower genital cancers are going to be harder to kind of manage is just that in the event that you end up having to need radiation therapy for management of that disease, cervical cancer being one of them, that is more or less going to then truly impact the decision in terms of that person's long-term ability to conceive. So for cervical cancer, many times if it can't be just managed managed surgically, you're going to end up having some radiation involved. That radiation will then make it harder to conceive afterwards, but more importantly, going to reduce the number of eggs available because it's directly affecting the eggs as they're going there. So many times you're going to end up having someone who's not going to actually have a whole lot of eggs left over. So it's going to be important to find out that information before. Fortunately, specifically with cervical cancer, it's not as hormonally responsive as breast cancer.
Yeah.
So those patients, you may end up having a little bit more time in terms of management than somebody who has active breast cancer. Breast cancer, if it's they are going to go through radiation, it's going to be upper body radiation, so you can shield the pelvis a little bit more. So those individuals may be able to get pregnant spontaneously at some point if they don't have embryo that's frozen. So therefore, that's the other part of it. A big part is just that the younger that the cancer is diagnosed, then the better the prognosis afterwards. But it's always going to be a fine line just in terms of what approaches to take, things to consider.
Wow, thank you so much for your expertise, Dr. Smikle. Are there any recommendations that you would give to anyone who's watching this who might be currently going through cancer treatment, recently diagnosed, or considering treatment options following cancer treatment?
Well, I think that the biggest thing to kind of understand is just that just hearing the diagnosis of cancer becomes overwhelming, and sometimes it's really hard to think about what their even thoughts are long term, just in terms of what to consider. Most times, the only thing you're basically considering is your own survival near term. So thinking about going through and preserving eggs, preserving sperm, creating embryos may not be part of the consideration. Oftentimes, you might actually see someone, especially if they're diagnosed with something really early and they're young, the first thing they're going to consider is then creating embryos. My thought to that individual is just that, basically, that's probably the time when you actually have to explore a greater variety of options. So you might say consider freezing eggs versus embryos, or doing this, getting the opportunity to do both. Only because after the initial event, if you will, there's a lot of things that come about. Many relationships crumble just from the diagnosis of cancer. So you can't go through basically with the expectation that the person who helped you through to navigate that cancer diagnosis is going to be there afterwards. So therefore, if you're creating embryos, what happens is just that commitment is then basically cemented, and you may actually have lost that opportunity to long term. So there's a whole host of things you have to kind of consider in terms of managing.
Because actually, freezing eggs has a much better success rate now than it used to, doesn't it? Rather than having to freeze embryos.
That is true. It depends on the age, but that's definitely true. And that's one of the reasons why I would say that, even in patients, who are older, it may be worthwhile to at least considering freezing eggs, only because, you want to have that potential to basically have a breadth of conversations, a breadth of decisions. I'm not saying it's ideal. If you're 40, then it may be worthwhile, freezing eggs with, fertilized with donor sperm, so you have more choices. But it's a really, really, tough process to kind of navigate emotionally when you're having all these considerations thrown at you in a really, really short period of time.
Yeah, it all makes complete sense. Thank you so much for your time today. And I'm finally meeting you in person on Saturday over in California, so really looking forward to that. And I believe Laurel Fertility Care are hosting an event on Saturday night, so for anyone who's interested in meeting the team local to the area and would like to come along, please do message us for more details. And I think that there's something very special that you're going to be announcing on Saturday night, which sort of a little bit further to what we've been discussing today is going to help someone on the preservation road. So that's amazing. And we really can't wait to meet the whole team in person on Saturday. It's been so long in the waiting, in the making, and yeah, it's going to be fantastic. So hopefully we'll see some familiar faces as well from those who have been following our lives over the last couple of years too.
Definitely looking forward to that. So wonderful.
Thank you everyone for joining. Thanks again, Dr. Smikle, and please do DM us for details from the team or to be put in touch. And Dr. Smikle and the team are writing an article all around cancer and treatment and fertility treatment based on everything we've discussed today. So if you want to find out more, it's coming soon. Please do subscribe to our newsletter to get this information, and do reach out to the team. So thank you once again.
Okay. All right. Wonderful talking to you. All right.
See you on Saturday. Thank you. Bye-bye. Bye.